Okay, let's unpack this. Imagine you're a specialist clinician, maybe, grappling with some really complex wounds or managing those persistent infections that just don't clear up.
Or maybe facing emergency situations where, the usual treatments just seem to hit a wall.
Exactly. And you're looking for solid resources, maybe eyeing up something serious like the Hyperbaric Medicine Indications Manual from the UHMS at the Undersea and Hyperbaric Medical Society.
And the UHMS, well, they're widely seen as the authority when it comes to the medical use of oxygen under pressure. This manual, edited by Enoch T. Huang, it's presented as pretty definitive.
Right. Chapters by leading experts in all sorts of relevant fields.
Mm-hmm.
So for you, our listener, maybe thinking about getting this manual, our mission here is to kind of act as a critical review. We've dived into excerpts.
Yeah, we've looked through key parts.
And we want to help you get a feel for what this book really offers, its scope, and critically, how relevant it might actually be to your day-to-day clinical calls. What are the core takeaways?
That's right. Let's maybe start at the very beginning. How the manual actually defines hyperbaric oxygen therapy, HBO. Because definitions matter, especially with payers.
Good point. So what's the official line according to UHMS and, say, CMS?
It's quite specific. They define it as breathing medical grade, near 100% oxygen while inside a pressurized chamber, and crucially, at a pressure of 1.4 atmospheres absolute, or ATA, or higher.
Okay, so breathing oxygen at normal pressure, even 100%, that doesn't count.
Nope, not according to this definition.
Or like those treatments where you just stick a limb in a bag or something?
Also not HBO therapy as the manual defines it. The whole person has to be under that increased pressure.
Got it. Does the manual touch on the history much?
Briefly. It mentions some really early stuff like 17th century, but mostly grounds the modern practice in naval research, 1930s, 1960s.
Decompression sickness, gas embolism,
Yeah,
that kind of thing.
exactly. Research that was really foundational for treatments still used today. And it notes the UHMS Hyperbaric Medicine Committee started back in '76.
And the point of that committee was?
Basically, rigorous review, bringing together experts, surgeons, internal medicine docs, emergency care, anesthesiology to look hard at potential uses.
So a multidisciplinary approach from the start.
Right. And the manual says for most proven applications, the pressures are typically between 2.0 and 3.0 ATA. Specific protocols are in the book, guiding that.
And it's usually not just one treatment session, is it?
Generally not, no. For most non-emergency stuff, it's a series. Daily treatments, often stretching over, say, 4 to 8 weeks.
Okay. Emergencies would be different, obviously.
Naturally, yeah. More urgent, maybe more frequent initially.
The manual also seems to place a lot of importance on who is actually delivering this therapy.
Oh, definitely. It stresses evaluation and supervision by physicians who've had specific undersea and hyperbaric medicine UHM training.
Right.
And the staff running the chambers, nurses, techs, ideally they should be certified too, like a CHT or CHRN.
And you mentioned the FDA.
Yeah, the manual points out that the FDA advises patients to look for UHMS-accredited facilities, which really underlines the manual's focus on, proper standards and safety.
Okay, let's shift gears then. Let's get into the meat of it from a clinician's viewpoint.
Yeah.
The specific conditions, the indications. Where does the manual say HBO actually fits in?
Well, it leads with a pretty critical emergency, arterial gas embolism, AGE.
What's the verdict there?
The manual uses strong language. It calls HBO the definitive treatment.
Definitive. That's quite a statement. Why? What's the mechanism?
It lays out several things. Obviously, the pressure physically shrinks the gas bubbles. That's key.
Boyle's law.
Right.
Yeah.
But it also helps the inert gas, usually nitrogen, diffuse out of the bubble faster. Plus, you're flooding the tissues with oxygen, which helps ischemic areas. And there are even sort of pharmacological effects,
Wait.
like reducing how inflammatory cells stick to the damaged blood vessel walls. So it's more than just squeezing the bubble.
Interesting. And timing. Is it get them in the chamber immediately or forget it?
Well, sooner is definitely better. The manual shows data linking shorter times to treatment with better outcomes. But, and this is important clinical nuance,
Yes.
it also notes that good responses have been seen even when treatment starts 24 hours or maybe even longer after the event happened. So it's not necessarily futile if there's a delay.
That's useful to know. Any first aid updates mentioned?
Yeah, an important one. Supine or recovery position for unconscious patients is good, but the old advice about head-down positioning, discouraged now. Risk of worsening brain swelling.
Okay, good practical point. Let's move to something many specialists deal with constantly, diabetic foot ulcers, DFUs, The manual gives this a lot of attention, it
It
seems.
really does, probably because they're so common and, there's established reimbursement. The basic thinking presented is, well, if a little oxygen is needed for healing,
Then maybe a lot more oxygen, hyperbaric oxygen, will boost healing.
that's the core rationale. But,
Mm.
and the manual is very clear on this, it's positioned as an adjunct therapy.
Meaning it doesn't replace standard wound care.
Absolutely not. It assumes you've already addressed the fundamentals. The manual uses the acronym VOIDS:
Voids.
vascular optimization, offloading, infection control, diabetes control, and surgical debridement. You got to do the basics first. HBO isn't magic.
So clinically, how does the manual suggest you pick which DFU patients might actually benefit? Is there a tool?
Yes, it really highlights TCPO measurements, transcutaneous oxygen pressure.
Ah, the skin oxygen reading.
Exactly. It points to studies like Fife's work suggesting that if you measure the TCPOs while the patient is in the chamber breathing oxygen, a reading over 200 millimilla Hg is a pretty good sign they'll heal well with HBOs.
And conversely.
Conversely, if the readings are poor, both on regular air and don't improve much in the chamber, that predicts failure. So it gives you an objective measure to help select patients.
Okay, that's helpful. Now, what about that tricky situation? The patient whose blood sugar control isn't perfect? Maybe their HbA1c is high? Does the manual just say no HBO?
Ugh. This is a really important nuance it tackles directly. The manual explicitly says that just because you can't get all those voids factors perfect,
Like the glucose control.
that shouldn't automatically rule out HBO. It actually references studies suggesting there isn't a direct link between a high HbA1c and whether a DFU heals with HBO or not.
So clinical judgment still plays a big role.
Exactly. It supports using your overall clinical assessment rather than just relying on a strict HbA1c number to decide about adding HBO. Protocols are typically daily, 2.0 to 2.5 ATA.
Okay, what about other chronic wounds,
Hmm.
like arterial insufficiency ulcers, AIUs?
For AIUs, the manual suggests thinking about HBO if the wound isn't healing despite standard care. Maybe revascularization wasn't possible or it didn't work.
And again, TCPO can help guide things.
Yes, it mentions using TCPO again, both baseline and in-chamber, to assess ischemia and guide the treatment pressure. Similar protocols to DFUs, generally.
What about venous stasis ulcers? They're incredibly common, right? Up to 90% of leg ulcers. Yeah.
Hugely common. And the manual does describe them, the pathophysiology, how they look, where they typically occur.
But does it give specific HBO treatment guidance for them?
Well, interestingly, based on the excerpts we reviewed, it describes VSUs, but doesn't seem to provide the same level of detail on specific HBO protocols or evidence summaries as it does for DFUs and AIUs. That's a notable point for someone considering the manual. The level of detail varies.
Okay. Good to know. What about some of the less common things like ulcers from systemic sclerosis or Raynaud's? Those can be really tough.
Yeah, for those really difficult intractable ulcers, the manual does cite case reports showing success with HBO,
What kind of protocols?
often around 2.4 ATA, maybe 30 treatments or so. And the reported outcomes were pretty good healing, better blood flow, sometimes avoiding amputation.
And vaso-occlusive crises. Thinking sickle cell here.
Right. The manual mentions a study where HBOs seem to significantly reduce pain scores and the need for painkillers in patients having a crisis, so a potential adjunct for managing severe pain in those situations.
Let's talk about gas gangrene. A true emergency.
Absolutely. The manual paints a scary picture, rapid, progressive, toxin-driven. It emphasizes a critical treatment triad: surgery, antibiotics, and HBO.
And HBO's role isn't just supportive.
No, it presents HBO as essential for stopping the production of the main culprit, the alpha toxin. It cites older studies suggesting much, much higher survival rates when HBO is started quickly alongside surgery and antibiotics compared to delaying it or not using it at all. It's presented as a cornerstone.
Okay. Shifting to surgical support, compromised grafts and flaps.
Here, the manual positions HBOS as a useful adjunct to help salvage failing grafts or flaps, maybe due to poor blood supply, ischemia, trauma, or if they're placed in tissue that was previously irradiated.
And the evidence level.
It cites various levels, including a randomized controlled trial, leading it to classify HBO here as Class 1B, meaning useful and effective, supported by good evidence.
What about major trauma? Crush injuries, traumatic ischemias.
Yeah, that chapter covers a spectrum, from replantations to severe crush injuries. The manual suggests using things like the Gustilo classification and even a wellness score to help objectively decide if adding HBO might improve limb salvage chances.
And it references specific studies.
It points to two randomized trials on crush injuries. Now, it acknowledges some methodological issues with them, but notes they both showed similar positive trends like better healing, fewer repeat surgeries, especially in older patients.
Now, one indication you mentioned the manual highlights as the most frequent in practice, delayed radiation injury, LRTI.
Yes, apparently making up about 40% of CMS billings for HBO, so a major use. The manual stresses, though, it's usually part of a multidisciplinary plan, often involving surgery, too.
And what's the underlying problem with radiation injury?
It happens late months, even years after the radiation. The radiation damages small blood vessels, leading to progressive chronic lack of oxygen or hypoxia in the tissues.
So how does HBOs help that?
The mechanism highlighted is stimulating angiogenesis and neovascularization, basically, growing new blood vessels into those oxygen-starved, damaged areas. The manual references key research, including Marx's work, showing this effect histologically and functionally.
And does it translate to better clinical outcomes?
According to the manual, yes. It reports high success rates, especially for osteoradionecrosis, ORN, of the jaw, where it says outcomes are excellent when HBOs is combined with surgery to remove the dead bone.
And that principle applies elsewhere.
Yes, the manual emphasizes that combining HBOs with surgical management of the damaged tissue is key. Whether it's ORN or radiation damage in the chest wall, bladder, or pelvis, it cites positive results across these areas.
It also mentioned a preventative role.
Right, using HBO before and after surgery in heavily irradiated fields to try and prevent wound healing complications. Sort of like prepping the tissue, proposed as potentially useful neoadjuvant therapy in some tough situations.
Okay. Now, the manual also brings up radiation sensitization for cancer treatment. That sounds a bit different.
It is. It's exploring the idea that oxygen can make hypoxic tumor cells, which are notoriously resistant, more sensitive to radiation therapy.
Is there much evidence?
It mentions some renewed interest studies, particularly from Japan, suggesting maybe irradiating patients shortly after an HBO session could boost tumor response. It also talks about a small phase 1 study with promising results.
What?
But this is also where the manual discusses some conflicting data. It mentions a retrospective review that raised a question, really about whether HBOs might potentially increase recurrence risk in a very specific group. Patients having salvage surgery for recurrent head and neck cancer who also had tissue necrosis.
That sounds complex.
Very. The manual presents the study author's interpretation, but also offers alternative explanations, stressing the study was small, the groups weren't matched. It highlights the complexity and the need for careful interpretation. Shows the manual isn't just listing things, but grappling with nuances.
Okay. What about sudden hearing loss? SSNHL.
Sudden sensorineural hearing loss, yeah. The manual describes it the sudden drop in hearing, mentions theories about blood flow problems as a possible cause.
And the role of HBO.
It reviews the evidence, but frankly, the picture seems less clear-cut than for, say, AG or ORN. It discusses studies with conflicting results or design issues. The manual's own summary table apparently shows a lot of variability in protocols and outcomes.
So, an area still under investigation.
It seems that way. Less definitive evidence presented compared to some other indications.
Intracranial abscess, brain abscess is also listed as an indication.
Yes, the manual includes it, usually managed with that triad, surgery, antibiotics, and HBO.
Yeah.
However, the excerpts we looked at didn't go into deep detail on the specific HBO protocols or evidence for ICI compared to, say, gas gangrene.
Got it. What about necrotizing soft tissue infections?
Yeah.
Necrotizing fasciitis,
Yeah.
flesh-eating bacteria, terrifying stuff.
Truly life and limb threatening, high mortality. The manual stresses the absolute necessity of prompt, aggressive surgical debridement, broad-spectrum antibiotics, and intensive supportive care. HBO is positioned as an important adjunctive therapy.
But how strong is the evidence specifically for the HBO part?
Well, the manual is quite upfront about the challenges here. It references a systematic review that found the evidence base is mostly lower-level studies, like case control, with lots of variability. So establishing really strong Class I evidence-based guidelines is difficult.
So who gets it then?
The manual suggests that if you have a high clinical suspicion or if the patient is immunocompromised, those are strong indicators to consider adding HBO to the mix, despite the evidence limitations.
And this is where the manual mentions the absolute contraindication.
Yes, important safety point, untreated pneumothorax collapsed lung, because pressurizing could turn it into a tension pneumothorax, which is life-threatening.
Right, and the ear issue.
Middle ear barotrauma is the most common side effect. Pressure difference. That's why the manual recommends considering myorotomy tubes, little ear tubes, for unconscious patients who can't clear their ears.
Okay. How about chronic refractory osteomyelitis?
Yeah.
Bone infections that just won't quit.
Yeah, really challenging cases. The manual uses a staging system, Cernimeter, to help guide things. It suggests HBO is most likely helpful as an adjunct for the more severe stages, stage 3 or 4, especially if there are other risk factors, and when standard surgery and antibiotics haven't worked or the infection is progressing.
And is there evidence it helps in those tough cases?
The manual cites reviews showing pretty decent success rates, like controlling the infection in patients who had previously failed standard treatments once HBO is added.
Any mention of cost? Because HBO sounds expensive.
Interestingly, yes. It includes an analysis suggesting that for these really difficult refractory osteo cases, adding HBO might actually decrease the total healthcare cost in the long run by helping to finally resolve the infection and avoiding the massive ongoing costs of failed standard care, hospital stays, more surgeries, etc. So despite the upfront cost, it could be cost-effective overall in select cases. The manual gives it Class 2 recommendations for certain osteo scenarios.
Fascinating. There's also a very specific indication, severe anemia.
Yes, but only when blood transfusion isn't possible, maybe refused for religious reasons, medical contraindications, or just unavailability.
So HBO replaces blood.
Not replaces, no. It acts as a temporary bridge. By breathing 100% oxygen under pressure, you dissolve a lot more oxygen directly into the blood plasma. This can help keep tissues oxygenated enough to survive, even with critically low hemoglobin, while the body works to make more red blood cells or another solution is found.
A temporary lifeline.
Exactly. A bridge therapy.
And finally, burns. Complex injuries.
Very complex. The manual touches on the pathophysiology, the microcirculation shutdown, the swelling, inflammation. It summarizes potential benefits of HBRO. Maybe reducing how far the burn damage spreads, potentially speeding healing by encouraging new blood vessel growth, maybe even helping with pain.
But you mentioned conflicting studies here, too.
Yes, the manual acknowledges that. Some studies showed benefit, others didn't, and there were criticisms of study designs. It's a tough area to research.
Why is it so tough?
Well, the manual points out the difficulty of doing large, multi-center randomized trials for severe burns, simply because, thankfully, major burns aren't common enough at any single center to easily recruit large numbers. It even mentions a planned Army study that had to be canceled.
But the manual still makes a case for it.
It does. It includes a quote suggesting that, based on research and clinical experience, HBO offers something unique for burn recovery, addressing multiple challenges in a way other therapies don't quite match.
Okay, so pulling back from all these specific conditions,
Yeah.
what does the manual offer on the sort of general science, the side effects we touched on, and the bigger picture of research in this field?
Well, it reiterates those key mechanisms we've mentioned, oxygen acting as a signaling molecule, driving neovascularization, antibacterial effects, maybe even things like mitochondrial transfer.
And the side effects you mentioned, ear barotrauma being commonest.
Right, middle ear barotrauma, ME. Risk factors include eustachian tube problems, being intubated, maybe neuropathy, myorotomy tubes can prevent it,
And lung barotrauma.
pulmonary barotrauma, PBT. That's about Boyle's law, again, trapped air expanding during decompression. Risk if someone holds their breath or has certain lung issues like blebs can cause serious problems, needs slow, controlled ascents.
Oxygen toxicity.
Mentioned as rare at the usual pressures, but possible. Can affect the CNS seizures are the main concern there, or the lungs, causing inflammation or reducing function over many treatments.
And the absolute contraindication to oxygen itself.
Bleomycin, the chemo drug. Big risk of severe lung toxicity if combined with high oxygen levels. So An absolute no-go.
The manual also seems pretty honest about the challenges around dosing and research evidence, doesn't it?
It really does. It talks about clinical equipoise, basically, disagreement or uncertainty in the medical community about the best way to dose HBOs for many conditions. Surveys show wide variation in protocols used out there.
So fundamental questions remain.
Yeah, like what's the ideal pressure? How long should each session be? How many sessions per week? What's the total duration? The manual often says, frankly, we don't always know the definitive answers.
And it addresses the criticism that hyperbaric medicine sometimes lacks top-tier evidence.
It does. It even introduces this idea of behavioral equipoise, suggesting that sometimes research gets stuck not just due to lack of data, but because different experts have strong, differing opinions based on their own experiences or biases. Leads to that extraordinary claims need extraordinary proof stance from skeptics when maybe the existing evidence is suggestive but not perfect.
Does it touch on the sham protocol debate? Like using low-pressure air as a placebo?
Yes, it mentions the debate over whether those low-pressure shams are truly inert or might have some physiological effects themselves, complicating study interpretation.
And it also seems wary of some clinics maybe overpromising.
Right. It expresses concern about facilities advertising treatments at very low pressures, like 1.3 ATA, maybe with lower oxygen concentrations, as if they're equivalent to the hospital-based HBOers protocols discussed in the manual for these serious medical conditions. It implies they're likely not physiologically the same.
Okay, so let's bring it all together. For you, the specialist clinician may be on the fence about buying the Hyperbaric Medicine Indications Manual. What's the main takeaway from our deep dive into these excerpts? What's its value proposition?
Based on what we've seen, the manual seems to position itself as a really comprehensive, expert-driven resource. It pulls together a huge amount of research and clinical experience. It offers detailed guidance, patient selection, protocols, the why behind using HBO for many conditions, backed by different levels of evidence.
But it's not just a cheerleader for HBO.
No, not at all. It also provides crucial info on the risks, the limitations, the contraindications, and, importantly, it places the whole field within the current research context. It's quite open about areas of uncertainty where more research is needed and ongoing debates.
So it sounds like it could be a really valuable guide if you're dealing with complex patients where HBO might be on the table. Gives you a structured way to think about it, grounded in the UHMS consensus view.
Exactly, especially for those refractory conditions where your standard treatments aren't quite cutting it. It frames HBOs not as some kind of cure-all, but as a potent adjunctive tool needing careful patient selection and application.
Right. It helps you navigate when and how to consider it based on the best available synthesis of evidence and expert opinion.
So, as you, our listener, weigh whether this manual should be on your shelf, maybe here's a final thought to ponder. Given everything we've discussed, the varying levels of evidence, the acknowledged research gaps, the clinical nuances, how does understanding all that influence your personal balance? That balance between relying on established expert consensus and clinical experience versus holding out for those definitive, high-quality randomized trials, especially when you're faced with a really challenging patient case and the options seem limited.